Good morning. Today we'll start studying the management of inherited bleeding disorders in pregnancy, which is taken from the Green Top Guideline 2017. And for the sake of simplicity, we'll only discuss the summary of recommendations and the appendix given at the end of this guideline. So many inherited bleeding disorders are covered in this guideline, but we'll start with hemophilia. Hemophilia is actually an X-linked condition, recessive condition, which occurs because of a reduction or the absence of factor 8 and factor 9. So the factor 8 deficiency will be called as hemophilia A and the factor 9 deficiency will be called as hemophilia B. And both of these deficiency or absence will cause bleeding. About 50% of hemophilic male fetuses or male babies will have no family history, and in this case 90% of the mothers are responsible who are the carriers. So a family tree construction of the maternal family should be made in order to find out who is at risk of being a carrier and then transferring it to the other fetus, male fetus. Okay. So for this purpose, you have to test the females for genetic mutations which is present in the family members in order to recognize the risk to the coming babies. There are different phenotypes and different severities of hemophilia A. So for this purpose, check the levels before pregnancy or at booking and before any invasive procedure in third trimester and in bleeding symptoms, right? Our aim should be to maintain a factor level of 0.5 international unit per ml and not less than that. Okay. The male fetuses are also at an increased risk of intracranial hemorrhages and extracranial hemorrhage. So genetic counseling should be provided to the couples or to the females who are carriers of hemophilia before pregnancy, and this should be done by an experienced and qualified clinical staff. Written informed consent should be taken before any genetic testing. You should be clear about the options which are available for the prenatal diagnosis. Well, for carriers, there is pre-implantation genetic diagnosis, or carriers of severe hemophilia should be offered sexual determination at 9 weeks of pregnancy by the cell-free fetal DNA, or the carriers of severe hemophilia should be offered the option of chorionic villi sampling at 18 to 14 weeks of gestation for prenatal diagnosis. If there is still diagnostic uncertainty, then offer third trimester amniocentesis in order to inform about the options of delivery. That is, for the male fetuses, elective lower segment C-section at 39 completed week of gestation should be performed, and for the female fetuses, the spontaneous vaginal delivery should be performed. Now, the antepartum management. Well, antenatal care should be provided by a multidisciplinary team which will involve the obstetricians and hematologists. Normally, a factor 8 level will increase in pregnancy, but the factor 9 level will remain stable. As I already mentioned, that the factor levels should be maintained at least 0.5 international unit per ml for any invasive or surgical procedure or spontaneous miscarriages, but for the treatment purpose, our aim should be to keep it at a level of 1 international unit per ml and not allowing it to drop below 0.5 international unit per ml. For the use of transamine or tranexamic acid, tranexamic acid can be given as a combination if the levels are below 0.5 international unit per ml, or if the levels are more than 0.5 IU per ml, then it can be given as a sole therapy and it should be continued until the bleeding settles. Then desmopressin is a drug which is given for the deficiency of factor 8, but it does not increase the levels of factor 9. So in case of factor 8 deficiency, desmopressin is given, but the main side effect is that it is an antidiuretic, so we have to restrict the fluid for 1 liter for 24 hours. And for example, if this is not possible, then you have to monitor the electrolytes because it causes hyponatremia and hypotension. If the desmopressin doesn't work or does not help, then we have to use a recombinant factor 8, and for factor 9 deficiency we give directly recombinant factor 9.